Extremely honored to have a wonderful local lecturer today, part of our internal grand rounds process. Most everybody knows, but for those who don't, Dr. Darden is one of our local superstars. He has been part of the Charlotte spine community for a very long time. Actually was I believe, a Davidson Wildcat, which we will use as the impetus for our CME color today. We'll have our color be red. And among Dr. Darden's many accomplishments and maybe most significant career accomplishment, aside from training hundreds of residents and fellows, is he served a term as the president of the Cervical Spine Research Society, one of the most important spine societies that many of us are members of, and proud to know Bruce. And today he's going to talk to us about one of his favorite topics that he is, again, world renowned for speaking on, which is cervical myelopathy. So without further ado, Bruce, we'll turn it over to you, and look forward to your talk this morning.
Thanks, Josh. I really appreciate the opportunity to give this talk. As you mentioned, it's something that I've done some research on, and as you'll see, have developed some guidelines through the Cervical Spine Research Society that may help us discern when and when not to do surgery for cervical spondylotic myelopathy. And what I'd like to do this morning to start off with is kind of give you a little overview of myelopathy, how to work it up, what to look for, radiographic test, and then to get into the literature about what's out there, as well as surgical options. I have nothing pertinent as far as the disclosure with this presentation. Cervical spondylotic myelopathy was first described in 1952 by Brain et al., which I think is a perfect name for a neurosurgeon. And they established the syndrome of cervical spondylotic myelopathy, and they outlined both the mechanical and vascular components of the disease. So an overview, CSM presents with spasticity, weakness, and numbness due to cervical cord compression. Typically, you see upper motor neuron changes below the lesion, lower motor neuron changes at the lesion, and the process is slowly progressive over years and months. In the US, there are approximately 100,000 cervical surgeries done a year, and this has doubled since the 1990s. CSM represents 20% of these surgeries, and the annual hospital charges for care of patients with CSM is over $2 billion. And the Institute of Medicine listed CSM as a top 100 national research priority for comparative effectiveness research. The prevalence of surgical CSM in the Netherlands was found to be approximately 1.6 per 100,000 inhabitants. In the US, the incidence and prevalence is between 4 and 6 per 100,000. So the etiology of the process can be varied. It can be due to spondylosis with osteophytic ridging, narrowing the cervical spinal canal. A large acute H&P can contribute to this. Spinal hypermobility from trauma, etc., can cause this. You can see degeneration superimposed on a congenitally small canal that can be part of the process. And lastly, ossification of the posterior longitudinal ligament can cause cervical spondylotic myelopathy. So the pathophysiology is chondro-osseous spurs plus a stenotic canal plus abnormal motion can lead to chronic cord asphyxia. This CT myelogram shows some circumferential pathology above with osteophytes and below thickening of the ligaments with the smaller areas narrowing the spinal canal. So as the process progresses, you can see with degeneration kyphosis, which can lead to cord tension, decreased vessel caliber. You can see gray matter changes. You can see axonal degeneration and demyelination. This can lead to gliosis. Further in the process, there can be anterior spinal artery vascular changes and eventually spinal cord atrophy. This is a normal cord on the left and then one with chronic compression and atrophy on the right. So in clinical presentation, spasticity is a sine qua non of this disease. Weakness occurs in about 2/3 of the patients. And as you can see, pain and temperature loss, dorsal column deficit, and atrophy and fasciculation a little bit over 50% of the time. Lhermitte sign, where you get electrical shock type feelings with either head compression or extension of the neck, is present in approximately 40% of the patients. And then you go down to neck pain and arm pain, which are not the most common presenting symptoms, and eventually sphincter loss, which is present in only approximately 15% of patients. There have been a number of attempts to classify myelopathy, and I won't belabor the point, but this is one of the most common classifications. It was by Kaplan in the mid-1980s, where they described this as either a lateral syndrome, where you see radiculopathy predominating, or what we call myeloradiculopathy these days, a medial syndrome where upper motor neuron changes are seen only, a combined process with upper motor neuron changes below the lesion, and then lower motor neuron changes at the lesion, the most common presentation. And then in a small subset of patients, a vascular component where there was acute onset, rapid progression, and poor prognosis. As I mentioned, ossification of the posterior longitudinal ligament can cause myelopathy. It is much more common in Asians, but as our population changes demographically, this is a process that we need to be familiar with, and not just through the Japanese or Korean literature. It's most common from C2 to C4. The age distribution is from 40 to 70. There's an equal sex distribution, and the exact cause is unknown. The photomicrograph on the right shows the process from C2 to C4. On physical exam, there are a number of things that you need to look for when you're doing a workup of these patients. One of the most important is to watch the patient walk, to watch them walk and then pivot and come back, tandem walking. These all can point towards spasticity. Provocative tests such as Lhermitte's and Sperling's are important. Rapid alternating movements with the hand can bring out spasticity, which in the hands can be loss of fine motor control. We look at deep tendon reflexes in both the upper and lower extremities. And then we look for pathological signs such as jaw jerk reflex, which would point towards an intracranial or brainstem lesion, Hoffman's, Babinski, Shimizu sign, and Oppenheimer sign. As we know, Hoffman's maneuver is when you flick the tip of the long finger and get rhythmic flexion of the thumb and index finger. Babinski's with stroking of the plantar aspect of the foot and getting upgoing toes on a positive exam. And Oppenheim test, where you stroke the tibial spine and get upgoing toes with this process as well. Inverted radial reflex, where instead of extension of the wrist with testing the brachioradialis reflex, you get flexion of the thumb and fingers, is a positive provocative test. There has been a blind zone in the upper cervical spine, approximately from C1 to C3, that did not have a reflex associated with it. Dr. Shimizu from Guma, Japan in the 90s described the scapulohumeral reflex, where you tap the tip of the acromion or the scapular spine, and a positive test results in elevation of the scapula and abduction of the humerus. The muscles involved are the trapezius, levator scapulae, and deltoid, and the reflex center is thought to be between C1 and C3. And this is the blind zone that previously did not have a named reflex for it. This is Dr. Shimizu on the right, enjoying himself at the one of the Cervical Spine Research Society meetings. A very great researcher. The differential diagnosis for CSM is legion. You need to think about all of these as you're working the patient up, and these confounders can be ALS, tumor, trauma, Guillain-Barré syndrome, normal pressure hydrocephalus, metabolic issues, and AV malformation, Chiari malformation. And then, as I mentioned, signs to look for a intracranial or brainstem lesion would be a positive jaw jerk reflex and cognitive dysfunction. In working up these patients from an imaging standpoint, our go-to test has always been MRI, but the other possible radiographic tests can be very important as well, as we'll mention. Plain radiography is important in that it gives you information about the overall alignment of the cervical spine, which is important for surgical decision-making. It can also show you deformity. It can point to ossification of the posterior longitudinal ligament, and the Torg-Pavlov ratio can give you information about the size of the spinal canal. The Torg ratio is just a ratio of the mid sagittal diameter of the canal over the mid sagittal diameter of the vertebral body. And this then results in a ratio. This can be somewhat skewed by very large individuals that have a elongated vertebral body, but it gives you a down and dirty estimation of the spinal canal. And this is another quick way to do it. Just transpose the vertebral body into the canal. With looking at the Torg ratio on plain radiographs, if you see a ratio of less than 0.75 or a canal diameter of less than 14, there's a high risk of CSM. And this shows the arrows pointing towards ossification of the posterior longitudinal ligament on plain radiographs. CT scan is very useful for evaluating OPLL and also looking at the neuroforamen. It's fast and simple, but it does have the disadvantages of radiation exposure. This shows OPLL with a large ossified mass in the canal. CT myelography has basically been supplanted primarily by MRI, but in patients that have older pacemakers or spinal cord stimulators, you still may need to do this and be familiar with the results. It can also show information about intramedullary or intradural tumors. MRI is obviously the procedure of choice. It gives the best information about intrinsic spinal cord disease. And you can see myelomalacia, the gray matter. You can see a decreased T1 signal and increased T2 signal. There's a better prognosis for the cord lesion when you only see an isolated T2 increased signal abnormality compared to a decreased T1 signal and an increased T2 signal abnormality. This is an older study, but it still has some relevance. There were surgical patients that were then evaluated prospectively and blinded to a number of individuals. And then they used a different test to try to predict the surgical lesion, and MRI was the most sensitive for being able to predict the surgical lesion compared to CT alone at only 50% of the patients. This shows a cord lesion at the C4-5 level on these two images. And this shows Chiari malformation and syrinx causing myelopathy. The natural history of CSM can vary. Clark and Robinson in 1956 described the condition with overall periods of stability with episodic worsening in most patients. 75% had episodic symptoms, 20% had a slow, steady progression, and only 5% had a rapid progression, which was probably vascular. There were no spontaneous regressions, and the patients fared worse if they were over 60 years old or a long duration of symptoms. And these are two factors to consider on board questions that come up not infrequently. Robbie Robinson at Johns Hopkins looked at 150 patients followed long-term. And again, they saw approximately 75% of the patients having episodic symptoms. Only 20% having a slow, steady progression, and 5% with that rapid onset. Conservative treatment is basically rarely beneficial long-term. Short-term measures include a cervical collar to limit motion, medication including non-steroidal anti-inflammatories, and muscle relaxants such as baclofen for spasticity. Physical therapy and corticosteroids can help short-term but are rarely beneficial long-term. No authors have recommended lengthy conservative treatment. The only observation of myelopathy can be following a soft disc herniation is thought to be possibly acceptable. And immobilization of corticosteroids can diminish acute symptoms while planning surgery. Traction and manipulation are obviously contraindicated, and epidural injection is controversial, which probably should not be done. Joe Epstein looked at a large series treated conservatively, and for these patients, 2/3 had no improvement and 26% deteriorated neurologically. There's very little head-to-head conservative versus surgical literature out there. That's because most clinicians do not feel like there is treatment equipoise between conservative and surgical treatment. The one randomized controlled trial, conservative versus operative, for mild to moderate non-progressive CSM, came out of the Czech Republic, and they followed these patients for 3 years, and they found no functional difference in the two groups. Sandpath out of Johns Hopkins with Tom Ducker looked at a prospective multi-center study, conservative versus non-operative, a small cohort, but found that the surgical cohort had worse disease, but that they, after surgery, had better functionality neurologically and better patient satisfaction after the surgery. And I stress that you may want to familiarize yourself with the JOA score. We use a modified JOA score in the West because if we had to score ourselves using chopsticks, I don't think too many people would fare very well on that. And then the Nurek classification, both of these are used fairly frequently in clinical studies for myelopathy. So prognostic factors, as you can see, early surgery is recommended. Better outcome in patients with symptoms less than a year, younger age at onset, fewer levels of involvement, or only unilateral motor deficit. And again, the last study, less than 1 year, that seems to be a trend for early intervention. Less favorable prognostic factors include the low T1 weighted MRI signal, clonus, spasticity, age over 75, and other studies have shown over 60 years of age, which kind of hits home here, and then the symptoms greater than a year. So surgical considerations, you should consider stability of the spine, sagittal alignment, size of the spinal canal, anterior versus posterior compressive lesions, and then the presence of OPLL. Treatment options can include a multi-level ACDF, multi-level corpectomy, or a combination of the two where you can do a hybrid procedure, laminectomy with or without fusion, laminoplasty, and then combined or 360 approaches. We'll go over these both, all of these very quickly and talk about pros and cons of each. So for ACDF, the main indications are anterior pathology, kyphosis, and 2 or fewer levels having to be treated. The pros include less postoperative pain, lower infection rate, ability to decompress and correct kyphosis. You can address pathology causing radiculopathy very well. And this has the lowest C5 palsy rate of all the procedures. The cons include if you're doing 3 or more levels, the complications increase, bone graft complications, dysphagia and dysphonia, and then difficulties treating posterior compressive pathologies, such as congenital stenosis. Corpectomy infusion, the main indication, this allows circumferential decompression of the ventral cord. The pros, again, more extensive decompression, fewer graft surfaces to fuse, and you can combine this with discectomy infusion. The cons include greater blood loss, increased OR time, and higher incidence of complications in some series. Cervical arthroplasty can also be done. This is primarily indicated for 1 to 2 level pathology confined to the disc space, and it's done primarily for soft disc herniations at the level where there's no retrovertebral pathology. Pros include preservation of segmental motion and maintenance of adequate stability. The cons are that you have that significant degenerative changes can increase the risk for recurrence or progression. So you have to do a thorough decompression if you're putting in a arthroplasty. Laminectomy alone, indications are posterior pathology with a neutral or lordotic alignment. The pros are direct approach. The cons are delayed post-op kyphosis, especially in the pediatric population, and not too many authors, except in certain circumstances where the patient is very degenerative without much motion with preserved lordosis. It's probably the only indication for doing laminectomy alone. Laminectomy infusion, very popular these days. It allows you to address posterior pathology with multi-level disease. It allows you to correct deformity. And some authors think that it helps with axial neck pain. And again, it allows the more extensive decompression and correction of deformity. The cons are it is dependent on cord drift back. There are hardware complications, and laminectomy infusion has the highest C5 palsy rate of any technique. Laminoplasty was developed as a tissue-sparing alternative for decompression versus laminectomy infusion or extensive anterior procedures where you have to go in and try to remove the large OPLL lesion. The early work came out of Japan. Hirabayashi in the late 70s first described this, and it has been popularized, especially with the advent of plates that keep the door open and allow early motion. The pros are the posterior elements are preserved. There's less postoperative scarring. There's retention of some motion, and it probably is a better alternative in the osteoporotic patient. The cons are that there's somewhat limited decompression, especially on the hinge side. There can be late instability, and there is the question of inconsistent relief with axial neck pain. And then the 360 approaches, these are indicated for significant focal kyphosis and posterior compressive pathology. You can use this for multi-level disease and obviously for instability as well. The pros are there's increased stabilization and increased decompression. The cons are is technically more challenging. There's a longer OR time and blood loss, which is a detriment sometimes with a sick spinal cord, and it may require staging if doing the entire process in one sitting is not feasible. So surgery for OPLL has evolved over time. It's very tempting, especially when you're starting out, to want to go in and remove this large anterior osteophytic lesion. But I think most of us have unfortunately learned with time that a lot of times the anterior dura is involved in this ossification process, and it's very troubling to be staring directly at the cord through a large dural defect with no great way to reconstruct the dura. So besides laminoplasty, a ventral method has been developed to overcome this, and this is called the floating method. And what you do in this technique is that through a corpectomy model, you thin the ossification of the posterior longitudinal ligament. You thin the OPLL lesion and then disconnect this laterally, proximally and distally from the surrounding bone, and then allow this to float anteriorly. And and then afterwards you reconstruct the anterior column as you would typically with a corpectomy model. The challenges are that the trough has to be at least 20 millimeters in width, and this can then put you fairly close to the vertebral arteries, as I'm pointing out with the cursor. It also has a higher risk of C5 palsy. There have been some studies that found that if your trough anteriorly with a corpectomy is wider than 18 millimeters, there's an increased chance of C5 palsy. This is a good study, and this was done out of Japan in 2008, where they described the K line. And the K line is a line that's measured from the center of the mid-sagittal canal at C2 to the mid-sagittal canal at C7. And if your anterior pathology is anterior to this line, that's called K-line positive. If the anterior pathology falls within the line, that's called K-line negative. This is an indicator of whether the cord can drift back away from the pathology. And in this study, as you can see, doing a laminoplasty for OPLL, percent recovery on the JOA score, the K-line positive patients did much better with a recovery, with a 66% recovery as compared to only 14% with K-line negative patients. The other thought with OPLL is progression, and these two studies showed approximately 70% chance of progression with OPLL after laminoplasty. And nobody wants to go back in on this after surgery. The second study by Lee showed that laminoplasty had a 45% recurrence rate at 5 years compared to laminectomy infusion of only 30% in a retrospective study with 5-year follow-up. This study looked at OPLL surgery, laminoplasty versus floating anterior fusion. This was a prospective case control study, and at 5-year follow-up, the recovery rates were better with the ventral surgery. So looking at the literature for the different surgical procedures, we'll hit on highlights, hopefully, of most of these. This is a very important study that is quoted quite a bit by Suda et al. And they looked at 150 patients that underwent a French door laminoplasty with 5-year follow-up. And they performed a multivariate regression analysis on their patients. They found that patients that had a normal MRI cord signal intensity, in other words, no increased cord signal intensity on T2 images, that the patients had better outcomes if they had less than 13 degrees of kyphosis on the initial films. So this is off quoted, and you will see that number, 13 degrees of kyphosis in training and board exams. The figure that's not quoted as frequently, but I think is just as important, is that Suda saw poorer outcomes if the patients had greater than 5 degrees of kyphosis with a cord signal change. So I think this is important to keep in mind, not just the overall alignment, but the alignment plus the cord signal change on MRI. There have been several meta-analyses done on the different surgical techniques. This is one comparing ACDF multi-level versus laminoplasty. And unfortunately, the literature on this topic is fairly poor when you look at the level of evidence. So they looked at 625 studies and only found 5 that they could include on their meta-analysis. And this study showed there was no difference in OR time, complication rate, or JOA score, ACDF versus laminoplasty. The advantages of each: ACDF had lower blood loss and better lordotic preservation, as you would expect. Laminoplasty, again, not a landmark conclusion, but had better range of motion. This study looked at multi-level discectomy versus corpectomy. And again, a meta-analysis. Both techniques had good outcomes. ACDF had better radiographic outcomes and fewer complications for multi-level CSM. Interestingly, there was no difference in hospital stay, OR time, infection rate, CSF leak, graft dislodgement, or pseudoarthrosis, which is a little bit surprising with what you normally think of with corpectomies. This study looked at laminoplasty versus lam fusion, a meta-analysis, and they were looking at the overall cervical alignment pre and post-op, and then their overall clinical outcome. And as you can see, there was equal improvement in a modified JOA score and VAS scores. There was no overall difference, interestingly, in sagittal alignment, but both groups progressed a few degrees in kyphosis at final follow-up. And this study looked at lam fusion versus laminoplasty in patients that had lordotic or neutral alignment. Again, a small cohort, like a lot of these studies. There was no difference in neurological improvement. Both cohorts lost 3 to 4 degrees of lordosis, but maintained a lordotic curve. Interestingly, there was a 2-time complication rate in the laminectomy and fusion group, which is very similar to what you see in the Edwards and Heller study, where John Heller and Reg Haid in the locker room at Emory decided to look at 13 patients each going forward, and again saw an increased complication rate with lam fusion, though the clinical outcomes were fairly similar. And not to digress, but in this study, the neck pain relief was fairly equal between laminectomy and fusion and laminoplasty. This is a US study, a matched cohort, 145 patients, where laminectomy and fusion had a higher blood loss and a higher complication rate, which is a trend here, but showed greater neurological improvement over laminoplasty. Laminoplasty did better when there was more lordosis present initially, especially if the patient had greater than 20 degrees of lordosis at the time of surgery. Our time doesn't really permit us to delve into C5 palsy directly. There have been a lot of theories, none of which have been proven conclusively. It's thought somewhat that C5 nerve roots have a more horizontal takeoff, and they have the longest length from the cord to the foramen, and cord drift back may be a part of this. There are also thoughts that burring or rotation of the cord with laminoplasty can contribute, and also an instrumented fusion where you try to restore lordosis can cause iatrogenic narrowing of the C4-5 foramen and thus cause C5 palsy. But suffice it to say, there's no conclusion as to why this occurs, but it can be a troubling complication. Most of these will improve if the patient has greater than 3 on manual muscle testing of the deltoid and biceps. If it's less, the recovery is less likely and is more prolonged, and you may want to consider going back in there and open up the foramen if the symptoms persist. But the rates, as you can see, will vary. Laminectomy and fusion has the highest rate overall in this meta-analysis, with the corpectomy and discectomy infusions having rates in the mid-range, and then laminoplasty being the lower at just over 4%. Well, what's in the literature about cervical disc arthroplasty? The first report was by Dan Rue and researchers that did an early post hoc evaluation from the IDE data and showed that this was safe in what they described as, quote, mild myelopathy, unquote. This could be a positive Hoffman's alone, 3+ deep tendon reflexes or mild myelopathy. A later study looks at a larger series with similar results, arthroplasty versus fusion for myelopathy, a 7-year follow-up, and they showed no increased risk for the arthroplasty cohort. So my thoughts are this is probably safe for 1 to 2 levels where there's no retrovertebral pathology. It probably is not appropriate where the patient has severe myelopathy. The decompression, especially if the pathology is mostly bony, needs to be comprehensive because there have been reports of recurrence of the disease behind the arthroplasty. And I personally would avoid arthroplasties that require significant chiseling or impacting because you worry about the water hammer effect injuring the cord during impaction. This study that was just presented at AANS by Zoe Gogwala and his team looked at patients that were randomized for equipoise by 15 surgeons and then looked at the treatment, anterior versus posterior, which could be lam fusion or laminoplasty. And they found that laminoplasty showed greatest improvements on SF36 scores, higher than anterior fusion and as well as posterior lam fusion. And complication rates, as you can see, were lower overall in laminoplasty, though all 3 groups had a similar rate of major complications, such as neurological injury, nerve root injury, C5 palsy, of approximately 16%. Interesting in this study are the expenses for each procedure. And as you can see, laminoplasty is approximately half the expense on hospital charges to both anterior fusion as well as lam fusion posteriorly. And opioid use in this study was lower in laminoplasty compared to the other 2 techniques, which is a little bit surprising compared to anterior fusion. Michael Failings and his team at Toronto Western has looked at the health economic evaluation of surgery for CSM. They looked at patients that received surgery at their center alone, and they looked at quality adjusted life year or quality gains versus ICER incremental cost utility ratios in these patients. And they made a broad assumption, which I think is a conservative consumption, saying that conservatively treated patients will not have a neurological decline in their lifetime. And so their quality adjusted life year came out to $34,000 with a willingness to pay of $58,000. And I think this was in Canadian dollars, if I'm not mistaken. And the ICER ratio was approximately 95%, which the World Health Organization rates as very cost effective. They had done a previous study looking at quality adjusted life years for CSM surgery versus other surgeries. And you can see very similarly, CSM was at $32,000 per quality. This compared to cataract surgery and total hip arthroplasties, which are very cost-effective surgeries, but it was very similar to total knee arthroplasty and gastric bypass in overall quality. So here's some factors that we look at that will promote one approach over the other, and this just provides some food for thought as you're planning surgery for these patients. First one is to look at overall sagittal alignments. If you see kyphosis, if this is fixed, then you're probably going to have to consider anterior procedure for these patients at least. If it's flexible, you can either do an anterior procedure or a posterior procedure with fusion. And then the number of levels involved. If it's 3 or greater, you need to consider posterior procedures, primarily laminoplasty if there's no instability. And if it's 2 or fewer, anterior surgery is probably favored over posterior procedures. age and comorbidities. The elderly patients with more comorbidities, posterior surgery is preferable over anterior procedures in most patients. If the patient's younger and healthier, they can withstand anterior procedures better. Instability, if it's present, you can either consider anterior procedures or posterior lam fusion. If there's no instability, posterior procedures, laminoplasty is probably preferable. And then a little bit controversial, again, as you saw in those studies, pre-op axial pain level, if it's high, fusion, both anterior, posterior, probably preferred. If it's low, laminoplasty is probably more favorable. I don't have time to go into all the conclusions of this systematic literature review. It was by the World Federation of Neurosurgical Societies. Their surgical committee had recommendations. I thought a good take-home point was from the natural course, and they mentioned that the natural course may vary for this disease. Progression is possible, but prediction is not well known. Some patients with severe disability can improve without treatments, but again, this is somewhat uncertain. But I think the take-home point with this is that patients with no symptoms but significant radiographic stenosis, their chance of developing myelopathy is 3% per year. So if you elect not to operate on patients with significant stenosis on radiographic imaging, that you need to follow these patients annually at least to make sure that their disease is not progressing, and they need to be educated on what to look for going forward. As Josh mentioned, I was president of the Cervical Spine Research Society in 2013 and 14, and as such, we had a chance to each year to do a presidential project. And what we elected to do was to develop guidelines with experts and methodologists for the treatments of cervical myelopathy. And having to use an independent methodological team is somewhat expensive. So we collaborated with AO Spine North America to develop these. And this was a several-year process. And this was introduced into the literature by Phalings and his team approximately 5 years ago. And so the purpose of developing guidelines was to implement evidence into practice and to focus on the improvement of the quality of care for these patients, to reduce healthcare variations, to represent the best judgment of a team of clinicians and methodologists, and use this as a basis for the measurement of performance of surgery. And so these were our conclusions that were published 3 years ago. And basically, in patients that have either moderate or severe CSM, the recommendation was for surgical intervention sooner rather than later. And both of these were strong recommendations with moderate overall evidence. And again, there's not very much level 1 or 2 evidence in the literature on CSM. For patients with mild CSM, the recommendation was either for surgical intervention or a supervised trial of structured rehab. And the recommendation would switch to surgical intervention if the non-operative patient deteriorates neurologically or fails to improve. This was a weak recommendation with very low or low evidence backing it. In patients that were not myelopathic, but with evidence of cord compression without signs or symptoms of radiculopathy, the recommendation was not for surgery, but to counsel these patients on the risk. And this again was a weak recommendation, and there was no evidence identified. This was based on expert opinion, and we had a number of so-called experts, both orthopedists and neurosurgeons, that weighed in on this recommendation. And finally, non-myelopathic patients with image evidence of cord compression with clinical evidence of radiculopathy only. And the recommendation was for surgical intervention or close follow-up. The grade for this was weak because of low evidence being involved. So a lot to cover in a period of time, but in summary, I think it's very important to correlate the symptoms with the patient's physical exam and imaging studies. There's no proven benefit for prophylactic decompression in asymptomatic patients. And patients with neck pain but no neurological symptoms, we recommend conservative methods and close follow-up. And in the vast majority of patients with advanced disease, fairly urgent surgery is recommended, and you need to be able to tailor the procedure to the pathology. So again, thank you, and I appreciate being able to present this study. Thank you.
Thank you, Bruce. That was fantastic. When we first picked, or when you first picked this topic and we looked at the timing of this, I didn't realize how close to the in-service exam we were going to be. So that was a gift to all the residents on this call who got a little tutorial in CSM prior to taking the OITE in a few weeks. Let me ask you a question to sort of start off the discussion. Literally just had this case last week. Dr. Seacrest and I were seeing a patient over at Myers Park Clinic with, clear spasticity, hyperreflexive, no question, CSM, has a, very tight canal, cord signal change, and he absolutely is refusing surgery. Very, very, we spent a lot of time. Eric was like despondent knowing the literature you described, and it was just wondering, can we make this guy have surgery? I would definitely call him a moderate to severe symptoms with severe cord compression. How do you handle that? From a ethical standpoint, medical legal standpoint, and just trying to make patients understand. And like many of our patients, there's definitely a medical literacy effect there, which is always hard to figure out, but we try to, make it in as simple terms as possible in terms of both just the pathology and the, natural history, but really a struggle for us. I think that was, a very impactful patient for him to see. How do you deal with a situation like that?
Well, I think it's somewhat of a tough patient because, we know that this process is more than likely not going to regress, and that hopefully and probably thankfully slowly his disease is going to progress, but hopefully it will not be that rapid vascular component where you get a quick spiraling down. I try to counsel these patients. I say, the sooner we can handle your disease, the better outcome you're going to have. If you let this sit, especially for over a year, you're probably not going to improve. So if you can live with your symptoms, do it. But the likelihood is that, if you wait too long, this is not going to improve, and you're going to be left in the situation that you're in. And these are the few patients that I try to push. Typically don't tell them you definitely will end up in a wheelchair, but it's a patient that I try to convince. And if I can't with the first setting, I try to follow them fairly frequently, maybe on a monthly basis, and check in with them and try to gently persuade them into getting this done.
Yeah, one of the other strategies I've used in the past is to try and make them come back in for follow-up with a family member, because sometimes you can convince that family member to talk them into it. Been a little harder with COVID rules when we don't have that opportunity to have a second set of ears in the room, and especially in that environment. Before a related question, which you partially answered already in your summary, was about those mild folks who aren't interested in surgery, probably would benefit. You recommended annual follow-up with those patients. That was the basis of my question. But the answer I have is, I know you said 1 year follow-up. Do you routinely image those people at 1 year, or is it just a clinical exam follow-up?
I think you at least need to see them once a year. I typically will see the patients back every 6 months at least.
Okay.
And, I try to counsel them and their family members about, what to expect with this disease, what to look for, the signs. And, to your point, I had a patient this week that had severe myelopathy with weakness, and it took getting 2 family members into a little exam room to be able to convince him that this really needed to be done. So even in the COVID era, sometimes we'll get more than one family member in there to really hit home the point.
Good. Any other questions from anybody for Dr. Darden?
Bruce, it's Eric Laxer. That was really superb. Thank you for doing such a good job with that review. Just a question, it's not unusual for us to see patients who have pretty extensive radiographic findings, yet clinically their presentation may not be that complex. So they might have cervical stenosis at multiple levels, but they might just come in with like a C6 or C7 radiculopathy and they have no myelopathic findings. Would you consider a smaller procedure in somebody like that, like just a foraminotomy? Is there support in the literature for that? Or do you think you need to be more aggressive given some of the natural history concerns that you mentioned?
I think, Eric, depending on how severe the disease is, I mean, if it's fairly extensive, I would lean towards at that point going ahead and doing the definitive procedure versus only a laminoforaminotomy. I'm just thinking having to go back in, where you are going to have some scar tissue and having to address that. The alternative, if the patient's not convinced, might be to do a 1-level ACDF to address that pathology, which doesn't, if you're thinking about going in posteriorly on the definitive procedure, might allow you to still be able to do that, as opposed to having to go back through the laminoforaminotomy scar. Just a thought there.
Hey, Hunter Dyer. Just a comment, really. I think that what makes it difficult to manage, one of the things that makes it difficult to manage spondylotic myelopathy is it takes so many years, as you know, with experience to help make decisions on taking care of these patients. It's sometimes difficult to teach the residents because most of this is in the outpatient setting. And I think the key things you discussed are that you have to really consider anterior versus posterior, surgical versus non-surgical, and many different options. And I think you would agree that over a lot of years of experience, you really get more of a feeling on the people that you should treat and the ones you should not. And I think it's just hugely important that we consider all of those different options that you discussed. Some people do well with anterior, some people front back, some people back only, laminoplasty versus fusion. And so I just want to, make that comment for the residents that it is a process learning to deal with this problem. And it's just so important that we consider all the different options because everybody's unique.
Yeah, I think that's a great point, Hunter. I don't think you can put every peg in a square or round hole. I think you have to have, a full armamentarium of surgical options and be comfortable with them all, because I love laminoplasty, but this fellow I saw this week, has a 2-level spondylo. So he's going to need, a posterior lam fusion. And, between those two, I mean, there's some patients that definitely need one versus the other. So I think if you try to do everything the same way, I think it's a little bit of a disservice for your patients. So, I mean, I think that's a good point. And I think it is an experience factor dealing with his patients and deciding when to pull the trigger and what to do for them. It's not always straightforward, and as you've seen, the literature isn't definitive one way or the other.
Right. And one other comment for the residents and the fellows, when I see a patient who has a gait impairment with myelopathy, a lot of times what tips them over into going for surgery is the fact that they are at such high risk for spinal cord injury with a fall. So although we can't always tell them that they're going to be better or have spinal cord improvement after decompression, we can give them some comfort in that if they fall because of their gait impairment, they may be less likely to have a, catastrophic spinal cord injury.
That's a good point. You can see these people pretty quickly, with Romberg's or tandem gait, or just trying to walk a straight line without an appliance. I think that's a great point. These people with a fall are much higher rate for, central cord or, complete cord injury. And as we know, and didn't have time to discuss today, how and when you handle a central cord acutely is another somewhat complicated process. So that's a great point.
Fantastic talk. Thanks so much.
Thanks, Hunter.
Bruce, thanks for leaving the residents, both ortho and neurosurgery, some ideas for future grand rounds. Timing of surgery for central cord. Good topic for discussion. Lots of pearls from everybody. Very much appreciate your talk and all of the learning here. There's no question that this topic will be on the in-service, and hopefully you provided everybody with some answers today. So thanks to everybody. Look forward to talking to everybody next week. And thanks again to Dr. Darden.
Thanks, Josh.
Thanks, Dr.